Let's return to our patient who is feeling weak, tired, and dizzy as we discuss treatments for beta blocker and calcium channel blocker toxicity. She also has a slow heart rate and low blood pressure, and her daughter suspects that she may have taken 2 doses of her beta blocker medication. Our ABC roadmap is essential here. While the airway and breathing aren't directly affected by toxicity, any patient with neurologic symptoms may require intervention. Because low blood sugar often accompanies beta blocker toxicity, make sure to check this early and correct it immediately. The circulation and electrocardiogram are the most important, so we'll spend most of our time discussing these. Our goal is to increase the patient's heart rate and blood pressure. An initial intervention that can quickly increase the heart rate is intravenous atropine. It's often stocked in crash carts, so it can be given quickly. But remember, the core issue with toxicity is the reduced influx of calcium, so our treatment has to increase this. Recall that there are 2 ways to cause calcium influx into heart muscle cells: directly through the L-type calcium channel, and indirectly by stimulating beta-adrenergic receptors, resulting in a reaction cascade that opens the calcium channel. Therefore, there are also 2 types of treatment. Direct treatment involves administering intravenous calcium salts to increase the amount of calcium that can pass through the channel. The indirect treatment is intravenous glucagon. It binds to its receptor, which activates an enzyme on the inside. This initiates an internal reaction cascade that opens the calcium channel. Going back to our bank analogy, think of these 2 treatments as increasing the number of people trying to get through the front door, representing calcium salts, and having a bank employee working as an accomplice to unlock the doors from the inside, representing glucagon. Now that we've supported the heart muscle's ability to contract with calcium salts and glucagon, it's important to stimulate both the heart rate via the sinoatrial and atrioventricular nodes and the strength of the heart's contraction via the His-Purkinje system. This can be done with intravenous epinephrine, also known as adrenaline. This hormone stimulates our fight-or-flight system and activates all alpha and beta receptors. So this should help increase the heart rate and blood pressure. The final treatment is hyperinsulinemia/euglycemia. This treatment isn't entirely understood, but it likely targets the dependence of heart muscle on glucose for energy. Our patient was evaluated in the emergency department and treated for presumed beta blocker toxicity. She was given both atropine and glucagon with improvement in her heart rate and blood pressure, and started on continuous intravenous fluids. Her electrocardiogram showed a prolonged QT interval, which is known to happen specifically with sotalol, so she was given intravenous magnesium in addition to calcium salts. Her sotalol was stopped completely, and her vital signs stabilized.
So I hope you liked this video. Absolutely make sure to check out the course this video was taken from and to register for a free trial account which will give you access to selected chapters of the course. If you want to learn how MedMastery can help you become a great clinician, make sure to watch the About MedMastery video. So thanks for watching, and I hope to see you again soon.